This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Jeff Ratliff with the Neurology podcast and Thomas Jefferson University. I'm here with Nanditha Rajamani and Andy Horn from the Center for Brain Circuit Therapeutics at Brigham and Women's Hospital in Boston. Nanditha and Andy are part of an authorship team of a paper published in May in Nature Communications titled Deep Brain Stimulation of Symptom-Specific Networks in Parkinson's Disease. In this study, the authors evaluated whether stimulating different brain networks via deep brain stimulation, or DBS, could lead to improvement in specific Parkinson's disease motor symptoms. They found that different white matter tracks, when stimulated, correlated with improvements in tremor, axial symptoms, particularly gait, bradykinesia, and rigidity, suggesting a more personalized approach to DBS therapy may be possible. So we've invited Nanditha and Andy to the podcast to discuss a little more about how these brain networks can be used in movement disorders therapies and what changes may be in store for DBS programming and surgery in Parkinson's in the future. Podcast listeners will recognize this isn't a new topic for us. I had a conversation with Michael Fox back in April of 2022, where we talked about brain network connectivity and how that could be used to inform DBS to avoid cognitive impairment after deep brain stimulation surgery. So, Nanditha and Andy, welcome to the podcast.
Hey, Jeff. It's great to be here. Thank you for inviting us.
Thank you, Jeff, for inviting us.
Awesome. We're happy to have you. And Andy, I want to start with a high-level overview. Can you summarize for us what you and your collaborative team learned about how DBS may be able to take specific white matter tracks into account in order to inform deep brain stimulation targeting and programming?
This story started when Nanditha joined my lab around, I think, 4 years ago. Is that right?
Yeah.
While she was super excited that DBS was really effective to treat most motor symptoms so well in patients with Parkinson's disease, she also noted that we had no clear idea of modulating which circuits would lead to improvements of exactly which symptoms. There was some general evidence about tremor being associated with cerebellar connections and hypokinetic symptoms with stimulating basal ganglia connections, but we didn't have a detailed blueprint of exactly which circuits mattered for which symptom. So Nanditha then did a deep dive into history, found out all about the old literature that used ablative lesion surgery to treat specific symptoms back in the day. One can learn a lot from this old literature because back in the day when you describe things first, you're much more extensive in your experiments and analyzing the effects much more in detail than nowadays. Because nowadays everything seems established, but it is not really established. So we could learn a lot from that. And then Nanditha sought to reproduce and extend these original findings using novel methodology, such as diffusion-based tractography, which became the main work for her PhD. So she had to develop her own method, which we call multi-track fiber filtering, and implemented multi-track fiber filtering and implemented this concept into our open source software LeadDBS. Soon, Nanditha had a first blueprint of which circuits should be stimulated to maximally improve tremor, bradykinesia, rigidity, gait, and other axial symptoms. So after that, she had the next big idea, which was to use this model to personalize DBS going forward. So in essence, we would want to stimulate the tremor circuit most if patients find tremor most burdensome, but also, for example, stimulate the bradykinesia track most when they had more bradykinesia. So essentially, we want to stimulate the symptoms that are most burdened in each patient. To do that, she came up with an algorithm we call a ClearTune, which blends symptom networks and finds the optimal setting for each patient. And the rest of this project was lots of validations. So we had to thank many collaborators and patients that shared their data and took part of this research to make it possible. And in total, I think you analyzed, Nanditha, correct me if I'm wrong, 237 patients or almost 500 DBS electrodes.
Yeah.
So to come up with the model, but then also to validate it in data not seen by the model.
It's an impressive tour de force of starting, it sounds like, from a place of not much knowledge about how to do this based on what you just said, Andy. And Nanditha, I'll turn to you. And given that summary, maybe you can inform us a little bit more about what did we know coming into the study? And it sounds like Andy said, a lot of your information was drawing from early 20th century literature about neurosurgical lesioning and ablation and how that clinical literature was informing us about different anatomical tracks associated with Parkinson's symptoms. And obviously, since then, fold in MR imaging and, as you said, diffusion tractography and other imaging modalities to help us get an even better picture of these white matter tracks. And so the question for you is, what did we already know about these white matter tracks and their association with Parkinson's motor symptoms? And what did we already know about our ability to address those symptoms with DBS when you set out?
To be noted here is the wealth of information that we already had on this topic, and it was generated a long time ago. And we highlighted in our paper about Rolf Hassler and the School of Stereotaxy in Freiburg, whose work inspired our work as well. Between 1950s to 1958, they reported their observation from 570 surgical lesion cases. So that's a lot of lesion cases that they worked on. And I think around 350 or 400 of them were all extrapyramidal motor disorders. And they were already observing at this time that targeting different subcortical nuclei resulted in different cortical responses. And of course, this would be a function of the pathways that are associated with these cortical nuclei. So, for instance, they chose to ablate the ventrolaris posterior as the main target for patients with hyperkinesia, that is high levels of tremor, possibly with the exception of rest tremor, since they observed that resulted in maximum reduction of tremor. And they also postulated that this nucleus projects to the primary motor cortex, which we now have validated with MR findings or with tractography and other new age technologies. And also, this was in contrast to observations on arresting rigidity, which they said requires the coagulation of the ventrolaris anterior, because the fibers from there project to another region of the cortex, that is the Brodmann area 6A alpha. So a lot has been done on this topic historically. This is, of course, not an exhaustive history, but then using modern techniques as well. Some scientists, for example, Harith Akram, has done really good work on mapping connectivity profiles of Parkinson's disease symptoms. And also, we should not discount the clinical heuristics that I think already exist. For instance, neurosurgeons routinely target the posterior lateral region of the STN for patients who have lots of tremor, and neurologists likely program more dorsal contacts for tremor. So in a way, this also is a bit of symptom-specific mapping or symptom-specific targeting and symptom-specific programming. And we don't believe that the general concept of the paper, that is to map different symptoms to different pathways, is essentially new. But what we really wanted to achieve here is to model these ideas in a three-dimensional connectomic model. And we wanted it to be readily useful, for example, with novel patients. And for this, we had to develop our methods, as Andy already spoke about. We had to introduce new methods and develop some new DBS or programming algorithms, which we call ClearTune. And so that was essentially how it was used and how we were inspired from that work to go from there.
I think that's really cool work. We're taking literature, as you said, that is 60, almost 70 years old, but also recognizing that a lot of what you gleaned from that literature and from the imaging literature is stuff we're already doing. Like you said, neurologists are programming along different portions of the electrode to try and target different clinical symptoms. And maybe they're getting there through trial and error in their programming visits with patients. Let's try stimulating here, see how the patient does. So we've gotten there lots of different ways, but now let's take a prospective algorithmic approach. How can we take this knowledge we have and give the clinician some tools to help predict how to program? And that does bring me back to you, Andy, and the paper comments that subthalamic nucleus stimulation in DBS has been really clinically impactful in Parkinson's. And we know about the motor benefits. We can talk about percentage improvements on a UPDRS Part 3. We can talk about a lot of these metrics for improvement. But as the paper says, it's not perfect. And I'm hoping you can comment on what are the limits or maybe the problems with the current state of deep brain stimulation, specifically of the subthalamic nucleus in Parkinson's, that maybe this algorithmic approach could try to address or improve upon.
So I totally agree with you. DBS can be fantastic in some patients, and in most patients actually profit a lot, but some do not, or some do not as much. So that's one point where my lab has heard it too often, hear me say millimeters do matter in DBS, and I really mean so. There's good evidence by now that just a 2 millimeter offset of the electrode being misplaced can bring you from, let's say, 80% motor improvement to 30%. Few millimeters really matter. And then for us as neuroimagers, that's really a challenge because typically that's the resolution we deal with, right? I think that is one additional achievement here to exactly map which specific sites we need to stimulate. And then I think the other point, even more clinically useful, hopefully in the future, would be that we have some symptoms that really respond well to DBS, such as tremor. But then there are other symptoms such as gait or gait problems, or most axial symptoms actually that would not respond as well. And often patients start presenting with tremor as their main complaint. Some do in the beginning of the course, but then over time, as the disease progresses, gait and other axial symptoms become the bigger problem. And currently, we really don't have much to address this in neurology. We don't have good responses to levodopa therapy of these symptoms, but also not to DBS. I totally agree with Nanditha, what she said, that the main findings somehow been known, but they've never been embedded in such a 3D model that we can actually apply. And then I think also Nanditha extended the findings, especially in that direction of gait and axial symptoms. So she identified that specific tracts between the subthalamic nucleus and the nigra, but also the brainstem, so PPN region, pedunculopontine nucleus region, would most associate with gait and axial symptom improvements. And of course, this is now really interesting to test prospectively if this actually will work, right? We can now use the model, we have it embedded in 3D, we can register it to new patients, localize their electrodes, and then switch on exactly the contacts that would help their gait. It remains to be seen that actually works, but I think that's truly novel also in this paper that we have a model for that and a hypothesis.
As you said, we know that certain symptoms, tremor being a great example, respond very well. But with time with Parkinson's, we know that axial symptoms like gait don't respond well both to medications, nor do they respond necessarily very well all the time to deep brain stimulation. As a matter of fact, might even be exacerbated or worsened by stimulation and can be very clinically salient and bothersome for patients. But now it sounds like with this algorithm and with compiling all this knowledge, looking at some other tracks that might be related to gait. You mentioned the PPN, the peduncular-pontine nucleus, as maybe a possible area to explore. Nanditha, I want to turn to you, and we've heard about this consolidation of knowledge and also about these specifically bothersome symptoms in Parkinson's that variably respond to deep brain stimulation in its current clinical practice. And so can you teach us a little bit more specifically about how did you take information from the collaborating centers that were partnered with you in this study, and how did you use that information to learn about specific tracks being stimulated for motor features like tremor, gait issues, rigidity, bradykinesia? How did you take all this data, put it together, and get meaningful knowledge out of it?
So we initially started off, as I mentioned, the project with 129 patients. So this was from 3 different centers. So we localized the electrodes in these patients to determine really accurately where they were implanted, and we calculated biophysical models around these electrodes based on the stimulation protocols which were already applied in clinical practice. So once we had this stimulation volume, we're able to correlate the tract activations with the symptom improvements that are there in the patients. And so this led to a model that really specifies which tracks correlate with improvements in which symptoms. And one thing that we think about here is, what are these tracks? Where do they come from? And so we had to really go all the way back to define these candidate pathways and tracks to begin with. And essentially this was because some of the publicly available connectomes of the subcortex was not of sufficient quality. Essentially that means that there wasn't enough representation of the tracks from or to projecting to the subthalamic nucleus, which is really what we wanted to focus on in this study. And so We curated tracks from a fantastic basal ganglia pathway atlas, which was published by Michael Peterson and Cameron McIntyre. But we also used tractography atlas published by Eric Middlebrooks, and we chose some of the tracks that were important to us. And we also added some additional tracks that were not defined in either of these two atlases. And for this, we really have to thank our co-authors, and especially a few people stand out. Helen Friedrich, and she organized a lot of validation aspects of these tracks. She collaborated with expert neuroanatomists like Vanessa Milane, and they really looked at dissections of the brain to ensure that these tracks that we're using are really represented in the human brain. So with this, we were able to have sufficient confidence that our tracks may allude to some reality that happens in the biology of this disease. So this was really a long process and involved a lot of people.
And so just to reiterate, like once these tracks were defined, we could then correlate how much they were stimulated with each symptom improvement. And that led to this symptom-specific track model that could then be used to map out this. We started this process, then realized, oh, the models we have are not good enough anatomically. And we had to go back to the drawing board and do this big work that Nanditha just mentioned. And yeah.
If I'm understanding, you had this discovery cohort that you had where you knew where their electrodes were and you knew their programming, their DBS stimulation parameters that they were currently undergoing. And then you were able to use some of the techniques that you had built to say, this patient with this electrode in this location with this stimulation parameters is probably having this tractor being stimulated. Let's go ahead and look at their clinical data and see where are we seeing the biggest gains or lack thereof in their clinical motor improvement. Am I understanding, again, at my level of understanding of what you did, does that seem like an appropriate synopsis?
I would say that in the discovery cohort, the reverse, where we measure which track, like how strongly are tracks stimulated across patients and how much does that correlate, let's say, with tremor improvements, right? And that will identify a few tracks that would correlate with tremor if they're, tremor improvement. Now, in the validation cohorts, it's the opposite, where we would make predictions. How much was the tremor cohort stimulated? That would give us a high prediction for tremor improvement. So that's how we then validate the model later in additional patients.
Got it. Okay. That is helpful that you can then use that algorithm to say, we think that these are the tracks that are going to be stimulated. These are the clinical symptoms we think will improve, to validate what you had learned from the discovery cohort. And so, Andy, we just talked about that, how we have this patient data set informing this knowledge about the tracks and the connections with the different Parkinson's motor features. And then you want to use all this data that we just talked about to inform an algorithm, which you guys named Cleartune, to help guide the DBS programming of the patients with regards to these tracks. And so teach us more about the algorithm. How did you do that validation and development? And what type of guidance or clinical information does it give to the person sitting there in the room holding the DBS programmer, so to speak?
We just talked about this validation process, right? So for a new patient that the model has not seen, we can localize their electrode, we can test which tracts are activated, and then make predictions of tremor improvement, bradykinesia improvements, and so on, right? So symptom improvements. Now, Nanditha used a brilliant trick where she just, to use Cleartune, she did the same exact thing in a given patient, but with lots of hypothetical stimulations, right? So she essentially tested everything possible in silico, calculated the biophysical models for all of these stimulation parameters, and then made predictions using the exact same idea. And then essentially the one with the highest predictions would be selected. But the cool thing is we can tune this. We can say we want to weight tremor strongly, right? This patient in front of us has a lot of tremor. So we want to weight the tremor predictions more than the bradykinesia predictions, or a mix of them, right? So we can linearly blend between these circuits and symptoms, which we call network blending. And the other challenging problem that she had to overcome was that in a normal DBS, setting procedure, there are 10 to the power of 10 possibilities or even more that you can program, right? So testing all of these in silico would potentially work, but would probably take a year or so, right? It takes a long time. So she had to, come up with an optimization regime, and that's, what we then call Cleartune, which takes a surrogate optimizer that uses a lightweight computational thing to approximate outcomes, and then iteratively uses the more expensive actual biophysical modeling calculations and then optimizes the problem, right? So it doesn't exhaustively search through the entire parameter space, but finds it with less computational cost. So I think currently you can run it in an hour or so. Yeah. So in a patient, took longer in the beginning, but we've been now thinking about applications of this and so on. Of course, want to optimize the code. And so currently it takes an hour to find one solution for a patient. So, but it really spits out one setting, depending on which symptoms you want to optimize. And you can, of course, also say to optimize all of them or a mixture of them in different weights. And then it would tell you, okay, put, 3 milliamps on.
Let's take that one step further, and you have this algorithm and you have the patient in front of you, and you say, to use your example, we want to emphasize tremor. Tremor is this patient's most bothersome symptom. It's one of their sort of primary goals of getting the DBS surgery completed is to improve their tremor. We put that information about where their electrodes are into ClearTune. It does the calculations and this prediction of which tracks do we want to target and how do we target them programming. Is the algorithm giving us a better set of programming parameters to address the patient's bothersome tremor than the quote-unquote old school way of going in and doing a monopolar mapping or testing out these different parameters and hoping the patient walks out of the office with, again, the clinical improvement that they hope to get from DBS? Are we doing that comparison yet, or is that down the road?
That was exactly the next step. So we did in a small set of patients as part of the paper, and we only included 5 patients. So this was not at all powered for any real comparison, see it more as a feasibility trial. But they did it still in a blinded fashion. So they had these 2 programs, somebody programmed them in, and then neither patient nor programmer knew. And we did measure the UPDRS in these 2 settings on 2 consecutive days, which was also great because it was an inpatient setting. So doing that with collaborators in Germany was really great. And the results are really promising. So out of the 5 patients, 4 did even better with ClearTune than standard of care, and 1 did very comparable. So reduction of, I think, 36 to 38 points in the 2 things. But the caveat is, and again, this is not significantly better, right? This was not powered for any significance, but, gives us at least some good preliminary data for the next real study. And then what I have to say, though, is that I think only 3 of the 5 preferred ClearTune over standard of care. So, not everybody did. And then I think 2 also had side effects in the ClearTune setting. So one had dyskinesias, one has dizziness. In fact, ClearTune did not know about side effects, right? So our model only includes improvement data. So this is certainly on the to-do list to, improve this. And currently we had a lot of trouble for ClearTune not always to suggest very high amplitudes. And we, applied some good computational tricks there. And now it doesn't, but still it would certainly help to include side effects in the model too. But still think, it can currently already reduce the parameter space drastically, right? So it could already give some good suggestions, and the clinician can try that. And then if there are side effects, you can always, ramp down the voltage again. So I think it can still potentially be useful as it is.
Andy, I think that's helpful. And I think that's really exciting that even in this small cohort of 5 patients, you're able to show that with this algorithmic approach, some of them are doing quite well. And certainly it doesn't sound like any of them are doing obviously worse and are similar to clinical standard of care. Again, noting some of those refinements you mentioned about making sure the algorithm isn't suggesting overly intense currents and stimulation parameters. Beyond that, what are the other steps to bringing this to primetime clinical practice?
What I can say is before ClearTune even started, so before Nanditha joined the lab, we had a precursor algorithm that's much simpler and more like sweet spot based, doesn't use connectomics, it's not symptom specific. It's called StimFit, was developed by Jan Rödiger together with our lab and also Andrea Kühn in Berlin. And Jan and Andrea took this further and have already published on a real prospective clinical trial, randomized trial, where they could show non-inferiority of StimFit. So that also builds upon LeadDBS-based reconstructions, gave us hope when we carried out this study that this could potentially be possible. So I think that algorithm is a little bit further along already. And we hope that bringing in connectomics and symptom specificity might potentially even be similar or better than standard of care. And you're absolutely right. Next step would be, of course, a clinical trial that needs to be funded and planned and everything. And then once There's good evidence that this actually works. Then, of course, the big question is how to make things simple, make them somehow FDA approved and available and so on. That's typically, of course, where industry has to come into play. And we're happy to be try to push the field forward and then work with industry to potentially develop these things. One big limitation that I see, and I've been, localizing electrodes for 12 years now, is that it really depends on doing that, including, I think, with software, commercially available, similar software, which, by the way, I think is great. Most tools that are out there are really good. It still is, what really matters on the details. It matters on the quality of the imaging. It matters on also the users really knowing what they're doing and so on. So I sometimes worry, is that still not ready for prime time in terms of can it actually be automatized and work robustly? See, you can click the automatic buttons in both lead DBS and commercial tools, and you would see electrodes, but are they really representing what's in the patient? So with increasing evidence that in my lab that we have to really have fantastic imaging and then dedicated people that localize electrodes. And that's one other hurdle that I see currently that we need to overcome as a field.
Yeah, I think, as you said earlier in the podcast, millimeters matter. And if we don't know where the electrodes are to a pretty high level of resolution, then we're starting off disadvantaged when then it comes to knowing which tracks are going to be stimulated by which parameters. I think that's an important point. But as you said, we've come a long way, even within the past few years. And I think looking ahead, there's a lot of optimism about some of these algorithmic and computationally informed programming parameters. For our listeners, I've been speaking with Nanditha Rajamani and Andy Horn about their paper published in Nature Communications titled Deep Brain Stimulation of Symptom-Specific Networks in Parkinson's. Thank you both for joining us. This has been fantastic, and thanks for teaching us.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.